go ahead and unmute that.
Yep.
All right, great. Well, our topic is going to be stress ulcer prophylaxis in critically ill patients today. Obviously, this is not a very exciting topic, but one that really there's a lot of questions surrounding, because there really isn't a true standard of care for this particular practice. In addition, it looks that over time we have changed our practice. You know, when we're talking from the 80s, 90s, and now, we seem to have changed a lot of our practice. So, you know, stress-related mucosal disease, as it's defined, can have multiple origins. The bottom line is you have loss of mucosal integrity, and that's probably what's leading to the problem. Why that's happening? Well, there's multiple theories, and there's multiple pathophysiologies. Some of those can be secondary to hypersecretion of acid, the microcirculation, which is ischemic from hypoperfusion, and then secondarily, when it gets reperfused, you get reperfusion injury to the gastric mucosa. And finally, the cells within the gastric lining may have decreased mucus production. All of these seem to occur in the state of stress, and in some studies, up to 50 to 75% of ICU patients have one of these happening within 24 to 48 hours of major stress or trauma. So when looking at this, there is some sort of basic science evidence and some clinical evidence that suggests that if you maintain gastric pH between 3.5 and 5, that decreases the degree of mucosal injury that you have, because you are now in a relatively more alkaline environment to where the gastric mucosa normally lives. In the 1990s, Dr. Cook did quite a bit of trials, and these are the ones that sort of are considered essentially landmark for this type of disease. There was a multi-center prospective trial, over 2,000 patients, and identified two independent factors, two major factors, that being coagulopathy and then mechanical ventilation greater than 48 hours, that can lead to higher risk of bleed. The incidence with these factors is, you know, about 3.5 to 4 times when these factors are present versus if they're not present. And according to her initial trials, the mortality, if there is a significant bleed, is very significant. A lot of that is questioned because some of the mortality has not been replicated in repeat trials over time, but that's a very significant number. So this is a big deal since the 90s, and it's been studied in multiple ways. So what are some options? Antacid, circulfate, H2 antagonists, proton pump inhibitors. There's also some prostaglandin inhibitors as well. Again, in the 90s, Dr. Cook did a bunch of trials that compared H2 receptor blockers to placebo and to circulfate, and with both of them, H2 receptor antagonists were deemed superior. That has been replicated in both primary randomized control trials and in meta-analyses in the 90s and again in the late 2000s. So now the big question is, well, what about H2 antagonists versus PPIs? Well, we know that 2/3 of the U.S. and UK ICU physicians use primarily H2 receptor antagonists as the primary treatment for stress ulcer prophylaxis. When we looked at our practice here at Gateway a couple of years ago, it reflected that we actually use probably more PPI here initially than H2 receptor antagonists. But due to some of the initiatives that we had, we've kind of reversed that to probably about 70 to 80% H2 receptor antagonist treatment and about 20 to 30% PPI. So in general, most physicians actually tend to use H2 receptor antagonists. What are some of the concerns? Well, one of the big concerns is cost of therapy, and this is very difficult to study because if you look at per unit, a PPI dose is going to be more expensive than that of an H2 receptor antagonist. But that depends on how you administer it, PO or IV, and the data related to complications is poor. So you really don't know the cost over time of a drug because you're not taking into account some of the complications. There's a theoretical risk of nosocomial pneumonia, although multiple studies over time, and the reason for this is as you alkalinize the gastric pH, the thought is the gut flora will tend to increase in amount, and that through essentially through aspiration can lead to increased risk of nosocomial pneumonia. This is, again, a theoretical risk. It's not been proven. It makes pathophysiologic sense, but not shown. There are some observational studies that have suggested an increased rate in C. diff in patients that are treated with both types of stress ulcer prophylaxis, both H2 receptor antagonists and PPIs. But again, these are observational studies that did not turn out to be statistically significant. So we really don't know. So nothing clearly states that one is better than the other in terms of complications. What did we know prior to this large meta-analysis that we're reviewing today? Well, in 2000, we knew from the 90s that H2 receptor antagonists were better than placebo. We knew they were better than sarcofate. But when compared to PPIs, in 2010, this is one of the meta-analyses. It was in the journal in Thailand, and it showed that PPIs were superior to H2 receptor antagonists, but did not lead to any mortality or length of stay changes. So that was a small. They only included 3 randomized control trials. In 2010, in critical care medicine, there was a study that published 7 randomized control trials, and this is one that was, prior to the one we're discussing today, was considered sort of the big trial. This is the one we used here to change our treatment regimen from PPIs to H2 receptor antagonists. And it showed that there really is no difference in bleeding or mortality or incidence of pneumonia, whether you use PPIs or H2 receptor antagonists. So, this kind of supports what the existing practice is across the country. And then this year, there have been, last year, there was a larger trial. And in that trial, it went back to the original data saying, now that we looked at 8 and 13 total studies, PPIs are now superior. The surviving sepsis guidelines, which were published in 2012, took this into account. In management of septic patients, they suggested we should be using stress ulcer prophylaxis. However, use of PPIs rather than H2 receptor antagonists is probably preferred. And again, it's great to see evidence based on this meta-analysis that was just coming out now. So this year, the goal was we've had conflicting data. Let's try to get to a definitive answer and do a much larger, much extensive review of existing literature. Do some sub-analyses and look at some risk factors and see whether these are good trials or not, and find which one is more superior. So this group, Al-Hazani's group, did a meta-analysis on PPIs versus H2 receptor antagonists in all critically ill patients. There was 2 physicians that were primarily the reviewers, and they selected randomized controlled trials that were either published as full trials or abstracts between 1948 and 2012. So they went all the way back till now. They looked at all adult critically ill patients in all critically ill populations, both medical and surgical. The control arm had patients with H2 receptor antagonist treatment, and the intervention arm was patients that received PPI. The primary outcome that they were looking at was bleeding, and they divided that into a clinically important bleeding and overt upper GI bleeding. And I'll kind of define this a little later, but it's important. What they mean by overt, essentially, is any sign of bleeding, like coffee ground emesis, bloody, if you have hematemesis, or if you have evidence of large hematochezia that you think is actually bleeding from the upper GI tract. Clinically important bleeding was defined as evidence of overt bleeding that leads to some clinical significance, like a drop in a crit or drop in pressures or, tachycardia or some other response clinically that you can say is secondary to bleeding. There's some secondary outcomes, which was incidence of nosocomial pneumonia, ICU mortality, length of stay, and rates of C. diff. They did a lot of statistics and a lot of risk adjustment and risk measurements to really study how good are each of these trials at what they're saying they're determining, how much bias they have, and what the overall quality of the trials are. So they used this Cochrane risk of bias tool, and both the degree and risk were classified as low, high, or unclear. They used a 10% difference as a clinically significant, less than 10% as being clinically significant and less likely to be based on just simple probability. The control assumptions were a 2% rate of clinically important bleeding and a 5% rate of overt GI bleeding. Again, this is a little higher than the prior rates, which were probably between 1 to 4%. So they assumed a little higher control rate than initially studied.
And why was that?
I don't know. They didn't necessarily say. They were trying to be a little bit more, in their minds, conservative. But I don't. I think this is a statistic trick. In some sense, by using a higher rate, they're going to be able to detect a difference without having to recruit that many patients. I mean, otherwise, the power they would need for a very, very low rate would be, very high, very low. So they would need to recruit a ton more patients to detect a smaller difference. So I think they assumed a higher rate, so they didn't need as many patients in the trial. So they initially selected quite a bit of trials, and they got down to 1,700 total patients from 14 randomized control trials, and 10 were fully published articles, and 4 of them were abstracts. They excluded any observational or sort of what they called quasi-randomized trials. So in their minds, these were the best quality trials we can have in over the course of time that this was studied. And this is going to be really hard to read, but just to sum it up, basically you have trials that exist all across from the 2000s. There's a couple of studies here from the late 90s. Majority of these trials use drugs that we don't use. Most of them use cimetidine or ranitidine as the primary H2 receptor blocker. Most of these trials use a variation of PPIs in terms of using omeprazole versus lansoprazole and pantoprazole. So they're using all 3 different types. Not all of them are IV or PO. They vary. Some of the practice is to just give PO PPIs, and some are just to give IV PPIs. So it all varies.
Are these all in the United States or they're international?
They're in UK, Italy, Iran. They're all over the place. So they're not only in the United States. They're also comprised of patients that are both medical, surgical, but they're all adult patient populations. There are some larger trials that I'll kind of go into that kind of dominate this data. The key difference here is not all of them measure things the same. So the definition of what bleeding in overt bleeding is different in each trial. For example, one trial from UK calls it a bloody nasogastric tube aspirate. Another trial claims that overt bleeding associated with only hemodynamic change. So there's some trials that are measuring clinically significant only and not overt, and there's other trials that are measuring any kind of bleeding. So again, the data is very questionable as to how much subjectivity there is in what you're calling bleeding versus not. So that's important because the outcomes of each of these trials are bleeding. And if you're looking at bleeding and you really don't have a clear definition of what bleeding is, it's kind of suspect what the outcomes are. So the bottom line is these trials, partly because of lack of blinding and partly because of this lack of definition of what bleeding really is, have very high risk of bias. About 11 of those really have a high or very unclear risk, and majority because they don't blind the providers to using either PPIs or H2 receptor antagonists. So just kind of go over a little bit of the results of these trials and what they did. So when looking at clinically important bleeding, so you're having some clinical significance, you can see that and this is a forest plot, so basically what you're seeing is anything to the left of the plot favors PPI, anything to the right of the plot favors H2 receptor antagonist. So across the board, you're seeing that it favors PPI in terms of risk of clinically important bleeding. Remember, in these trials, you don't have the same definition of what bleeding is. So across the board, you don't have the same definition. However, you're still getting PPI to be what's favored. Not all these trials are clinically significant. As you can see, some of them cross a zero, so they cross one, so they're going over to the other side. So those are essentially insignificant. According to them, the risk ratio is 0.36, so it's a significant. It is significant. It's a p-value of 0.002, so it is a significant difference between PPIs and estrogen receptor antagonists. But there's something curious on this plot. I'm curious what you guys kind of take on this. Take a look at the weight of what is affecting the data. What do you guys think? Yeah.
One study, that one study is.
Exactly. So 6. So 1, 2,
and it's like right
3,
there,
4, 5.
ratios are not so
Exactly. 5 of the trials had no events whatsoever for bleeding, and
with either drug.
Either drug, and 46% of the weight of the of this analysis is determined by the Conrad study. So it's largely based on one study. And that's going to be important. We're going to talk about that in a little bit. But let's say it was true. According to this, overt clinical bleeding is significantly affected whether you use PPIs or ACE receptor antagonists. And the overall, but the overall incidence is not dramatically different. We're not talking about a massive difference in the overall incidence. In fact, the first trial that's heavily weighted, if you look at the odds ratio just of that trial, it crosses 1. So it really is, even though it's heavily weighted, it's insignificant if you just solely look at that trial. Looking at overt GI bleeding, you find something very similar to what you just found in the last study, in the last forest plot. Again, if you look at a conglomerate of data, overall, you're seeing that it's a clinically significant difference, and you have a 65% higher chance of having it with 65% more likely to have it with PPIs. However, it's again weighted by the Conrad study and a single study, and there's multiple other trials that show no overt GI bleeding whatsoever. In terms of secondary outcomes, there is absolutely no difference whatsoever in nosocomial pneumonia, ICU mortality, length of stay, and C. diff wasn't even reported for any of the trials that they studied. What confounds this further in terms of the actual data is that when you look at the quality of the study, and this is a subgroup analysis of clinically important bleeding, the studies that were low risk of bias were more likely to, sorry, hang on a second. I'm trying to put this together in right words. Studies that were actually a low risk of bias didn't affect the data as much as the studies that were higher risk of bias. So the studies that were higher unclear risk of the bias actually led to what data you see. So the data is being affected or controlled by trials that are at high risk of bias, and it's consistent for both types of bleeding, and that's very clinically significant. So confound that with the fact that the rest of your data is primarily determined by a weight of one single trial. This is a big problem. I mean, in this meta-analysis, you're seeing data that's really coming from one trial and a very heavily biased towards those that have poor validity. So the authors confidently concluded that PPIs are more effective than ACE receptor antagonists in preventing overt and clinically significant bleeding, and there was no difference in secondary outcomes. And because this was such a diverse population, and looking at the rest of these ICU type, route, frequency, geographic location, and the fact that all these subgroups were not significant, that the results can be generalized across all populations. So one strength that I'll certainly give the authors is they definitely went through and picked what was existed as a good trial up to 2012 in our literature. They captured more trials than any other prior meta-analysis. And they did a pretty good sensitivity analysis with regards to how much effect this has, regardless of what type of ICU you have or what the route of the drug is. But as we kind of talked about, there is a lot of limitations to this trial. There's variable risk of bias. The higher quality trials showed a lesser treatment effect. So the treatment effect that you're seeing is likely because of the trials that were not as good. The definitions of the primary outcome varied completely across each of the trials, and there were some trials that didn't even have any definition to begin with. The rates of outcomes also varied. In fact, one of the trials had an incidence of bleeding of 31%, and I don't know how or when you can have an incidence that high. That questions both the care and what they're actually studying. And it probably is because that trial didn't have a definition of what the outcome was. It's not really adjusted for any risk factor, so you don't know it's because they were mechanically ventilated or because they were coagulopathic or because they were, septic and severe stress. We didn't have data on all the trials, and one of the things that I think is very significant is that it was weighted on primarily a single trial. So, this Conrad trial, I'm just going to talk about this briefly. Go back to remind myself. Basically, just so you know, these were patients that were mechanically ventilated for greater than 48 hours and had Apache scores greater than 11 and at least had one more risk factor for stress ulcers. So they seem to be very appropriate patients. There were 359 patients. The control group received cimetidine 300 milligram bolus and then an infusion. And the intervention group received omeprazole 40 milligrams by an NG twice a day. This was continued for 14 days unless they got extubated. And when they got extubated, they'd stop. They wouldn't continue it. And they measured clinically important and overt bleeding. And they had a pretty strong definition that bright red blood not clearing after tube adjustment or lavage for 5 minutes. So you're lavaging the tube and the bright red blood's not clearing. So that's fairly consistent. 8 hours of persistent gastrocult positive coffee grounds with aspirates. Persistent gastrocult coffee grounds over 2 to 4 hours on day 3 to 14. So they were using evidence of blood and that was significant after lavage as being clinically significant. It was a randomized, controlled, double-blind trial. The problem was it was Phase 3 study that was supported by Centeris. And Centeris is the drug company that makes omeprazole. So it leads you to believe that there was definitely something there that, methodologically, it was a good study. They had the right patient population, but it really questions the fact that, this is a drug-sponsored trial that's not been able to be replicated in other arenas as an individual randomized control trial. So it was there to push the drug out. But it was overall a low risk of bias because it was blinded. It was a relatively good quality trial, and it had what at that time would be considered a decent, aligned with standard of care. So that's just kind of a little bit about that trial.
I'm sorry. What were the drugs and doses that they used?
Omeprazole, 40 milligrams NG twice a day.
That's for loading.
For loading, and then 40 a day after that.
Okay.
And then cimetidine 300 milligram IV bolus followed by an infusion of 50 an hour.
Huh.
Which is a weird choice.
I would say they don't really sound like prophylactic doses. That sounds more like a treatment kind of regimen. Would you ever put somebody on an infusion?
No.
How would you determine that those are suited?
Well, I can tell you that across the board, if you look at all the trials, infusion of ACE receptor antagonists seem to be the drug of choice, seem to be the path of choice. So ranitidine infusion and cimetidine infusions were used in several of these trials.
Yeah, like in Europe.
Yeah, I was going to say maybe it's the difference in practice.
This is in the U.S.
I know no hospital that I've practiced at, I haven't practiced at many, but we haven't used those particular products because of high risk of drug interactions. So,
do we even have cimetidine here now?
We don't. We have ranitidine, I believe, we have one other H2, but they usually only use it in OB. because they have specific protocols for OB that differ. In the hospital, though, I think if you order ranitidine, you'll probably get interchange tested.
Okay. Yeah, I've never seen any others ordered here.
And I think that's the main reason is because of drug interactions with those, because those have more like CYP interactions than tested.
Because, you know, there is basically, I think there was one trial that actually used famotidine. Everybody else either used ranitidine or cimetidine. And often it was used as an infusion at very high doses. The one interesting thing is none of the trials showed any increase in pneumonia rates. Didn't measure C. diff, but didn't alter mortality. Didn't alter.
Yeah, that seems odd.
What seems odd about that to you? About the, I know what seems odd to me.
Well,
if the data from the 90s was true and that mortality was really 50% for those that bled versus 9%, and they're stating that people had more bleeds with PPI, why was there no difference in mortality at all in any trial? I mean, something doesn't make sense. I don't know, Gijo, what do you think about that? What are your thoughts in terms of, are you still there?
Yeah, I'm still here.
Why do you think that might be?
I have no idea, man. It's such high bleeding. I don't think we ever see that much bleeding. To begin with, the last year, or at least at Gateway, looking at all the patients, they've all been on H2 blockers. How many times have we had a GI bleed in the ICU? I don't think there's been even a single case, at least not when I was around there. So I don't know if any of you guys have seen. So it's all a question of relevance. I don't know.
For me, based on what you said and how they stratified patients in that trial, that they had to not only be mechanically ventilated but also have an additional risk factor, to me what that means is maybe not across the board everyone needs a PPI, but maybe more high-risk patients, like you would stratify based on, are they just mechanically ventilated or do they have mechanical ventilation plus more risk factors? Like, what if you have someone who just comes in and is on the vent? Do they need a PPI, with no history, no coagulopathy? You know what I mean? I think that was the original, that's why all those additional studies came out.
The problem is
these other things.
this meta-analysis doesn't answer that.
Oh,
they
no.
didn't stratify based on risk factors.
No. I guess
that other trials did include patients that had more than just mechanical ventilation, and they showed that it was a difference when using PPI versus not.
Right.
But how many patients do we actually have that are only on this ventilator and have to look at?
Well, what's the other risk factor, though? You have to have a coagulopathy, meaning an elevated INR.
So there's...
What's the criteria? What does that mean? That's pretty vague.
So coagulopathy is very vague. I think it was an INR of 1.6, I want to say. But coagulopathy and mechanical ventilation are considered the two strong indicators. Right. Then this is a non-trauma, non-burn unit. Then for our population, sepsis and severe sepsis is a minor criteria. Advanced age steroids are minor criteria. I think severe hypothermia is another one. And shock. Yeah, evidence of shock. So these are all sort of, you take it with there's nothing that tells you that it's going to improve outcomes. There's no trials, as opposed to ones that support with the other patients. Yeah. But I think, Gigi, you bring up a really good point. I think there's so much done about this, and when we look, is this problem really that big?
I don't think so. I mean, how many people do we have that came in, that didn't come in? I mean, the people who get admitted because they're bleeding, that's different. But how many people come in and started bleeding?
Sporadically.
One or the other.
I
don't know that I can remember any.
But the incidence is low to start with, even in the trials.
It's very low.
So that's why you're not seeing as much, because the incidence is so low. And if it's and again, it depends on your definition, of how you're defining that clinically important versus over GI bleeding. So
the other thing that's strange about this too is, I know they say here, but upper gastrointestinal mucosal lesions can be found in 75 to 100% of ICU patients. How many people get scoped and they find nothing? Yeah. I mean, there's a lot too, so I don't know what to do with those numbers.
And that was in the 90s, I think, that that trial was in the, and
Yeah, that's.
I think it was in the mid-90s. You know, this is a tough one for me because I'm like, what do I do with this? Because, you know, I thought of sort of one, you know, what are our sort of next steps and how does this compare to our current practice? And what I was thinking more about was rates of event. And I totally agree with you guys. I don't know. I mean, what's your nursing
Are you thinking
experience?
just not treating at all?
No, I'm not saying not treating at all. I don't think we can not treat. But how much do you believe the hype, I guess, believe the data that this is a dramatic difference of one drug over the other?
Based
No, you know,
how should we say that using H2 receptor antagonists? You guys think it was
Yeah, I have a number. I don't remember what it was last year. Like per month, it's like $2,000 per month, just in the ICU. I was only, so I don't know. We did that hospital wide.
you know, it's like what, in this paper they say 1 in 78. Like if you treat 78, you're saving one event.
Correct.
And, I mean, you know, and that event is not necessarily clinically significant. It's just for all.
For all bleeding events, yeah.
And so if you actually take into clinically significant event, it's probably even less.
What is a good number to treat? What is statistically, what would you
I think it depends on the effect, it depends on the cost, and then it depends on what, you know, the overall outcome. It's hard to calculate. There's ways you can calculate it, but it's not, you know.
What the number needed to treat.
Yeah.
Well, I always think that's weird because, like, when you look at stuff like Lipitor, the number needed to treat to save a life for, like, mortality benefit is, like, in the hundreds. Where, like, Zygris, when the original trials that came out, the number needed to treat was, like, 7 or something, which seems like, why don't more people use this? Because the number is 7. Like, you only need to treat 7 people and then you save somebody. But, like, we don't even use that anymore. And Lipitor, like, everybody and their mother's on Lipitor. So I think it is just you stratify based on risk and what's the, you know.
The cost of the drug.
Yeah.
I mean, the cost difference at one institution in one ICU is nothing. Now, if you take this and do it at 40 hospitals across the board in the system, you're talking about a lot of cost difference, right? I mean, it's $80,000 a month. And
the other question, I guess, the answer that you need is what does one GI bleed cost?
so,
Let's say you get a clinically significant GI bleed that requires, you know, endoscopy and infusion, or transfusions and clipping, and what additional length of stay. So how many would you need to treat empirically to cover the cost of that?
So the same group that did that trial, Barton, what the heck's the name? Barklin in American Journal of Gastroenterology, in the same year last year did a cost analysis and I think the editorial comments on the cost effectiveness, and they actually studied that, but they assumed some numbers that had to do with the risk of, so they knew the cost, but they assumed how many events would occur. And based on those assumptions, it showed that even though PPIs are maybe more expensive now, they've saved cost effective in the long run. I think it was in Journal of Value something, not the editorial or one of the other two marks at it. But again, this is not well studied. I mean, how can, we don't even really know what the incidence is.
Well, what is it, for us too, what's the cost between, because I didn't know this, but alluding to IV PPIs versus NO PPIs. What is the cost of between those?
I don't remember. I think like the oral PPIs are like $1.50 or something per dose or something like that, and then the IV is like closer to $4.
So in Flip,
per
when
dose.
you went to PO, the PPIs were actually
Cheaper than the
H2.
Maybe we could at least do that. I mean, unless there's a reason to not use the gut.
Right. So PO PPIs were cheaper than IV H2 receptor antagonists.
That's not what we're
Because, well, for some people, depending on the dose, because some people, depending on their renal function, get their doses twice a day and others get it once a day.
Of what?
H2.
H2.
Right. So for some people, it still is cheaper to do an H2 if they're renal, because they're only getting it once a day.
And
I mean, but we also we're not like exclusively H2. Like, we still leave PPIs on if they have a history of GERD, if they were on a PPI at home. So it's not like we aren't using PPIs at all, because we have the data, like, based on usage in Pyxis. We still, 20 to 30% of our patients do get, or at least dispensing, are getting PPIs. And that's not including infusions. That's just intermittent PPIs.
At least for me, I can tell you, I don't think, I can rarely think of an opportunity where somebody's on an IV protonics that I think, oh, let's just switch this to PO, unless they're pretty much we're de-escalating lines and getting them out of it. But while they're sitting there, I don't think I ever go, like, does this guy really need an IV PPI, or do you know what a
that's because I usually change it. Well, we have IV to PO protocols, so if patients are tolerating oral and they're not on an infusion, if they're just on intermittent, then I just change it to the equivalent oral because there's a policy that says that I can.
And that's something pharmacy is allowed to do.
Correct. That's gone through the system P&T and the facility P&T saying that.
Before looking at this, I was fairly comfortable using ACE2 receptor antagonists as my primary treatment for everybody across the board. I don't think this changes my mind, but I'm not as comfortable, I guess, as I was. This doesn't change my mind personally that I think PPIs are now superior, because this data is really not that great. It's very biased. It's really based on not much. But I'm not as comfortable that it's always the best thing for every patient. Mm-hmm. And I think kind of what you're talking about, maybe there are some patients where it may be better. I don't think we know, but I'm not as comfortable with everyone. What do you guys think? Does this change anything that you do normally based in your practice?
I use PPIs if they have, like, if certain risk factors,
Give me an idea of what you're talking about.
If they're on high dose of steroids, they're on the vent, they have septic shock. I sometimes put them on PPI.
But how do you make that decision? Because to me, that's stressful for prophylaxis.
Yeah, it's just the risk. We used to use PPIs all the time. So, I still put them on H2 receptor blockers, but, from my past, experience, I tend to still use PPIs where I think, there is a very high risk for, that they might bleed, and if they bleed, they don't do well, like in the sense that they're really sick, and any event will result in their deterioration. Not, if they bleed, that's basically going to decompensate them more. And then I don't think it's necessarily that there's evidence, but it's just that it's like your patient is so sick that you don't want anything else to add to that. You know what I mean? They're on like tons of pressors, they're on, high dose of steroids, significant vent support, and I might go with the PPIO. Now, if you look at the data, one thing is interesting is all the studies, there's nothing on this side, right? So either they're equivalent or PPI is better.
Right.
There's nothing that says H2 receptors are superior.
Correct.
Okay. So you're taking H2 receptors over PPI because of the cost, pretty much, and there's some concern about C. diff, which this study did not address. And the nosocomial pneumonia and stuff they say is not much different. So maybe the difference is so small, it's very small. The truth is somewhere in between where it's equal or it's better. And most of the studies are on the left or of the plot line. So it has to be that there is some benefit. Maybe it's not enough to, because the events are so low, and the magnitude is so small that the studies won't ever show you that there's a big difference.
Okay.
So
based on that statement, should we only use PPI?
I do it the other way around. I only use PPIs for two reasons. One, if they're on at home, and two, if they came and were on a drip and we de-escalated, and that's it. Those are the only times I use PPIs.
But then you're not using it for stress ulcer prophylaxis.
Right, that's what I'm saying. I don't use
H2 receptors.
So you don't use PPIs?
I don't use them, except for those two reasons, I don't use PPIs.
DJ, what's your experience for this?
Well, the thing is, before I came here, we used to operate in two hospitals. So at the VA, we had to use a H2 blocker. That was the rule. The other hospital, we could use a PPI. And after I came here, I've always been using H2 blockers because that's the protocol. I haven't seen any big difference, whether they were on a H2 blocker or PPI as to their outcome. So I just stick with the H2 blocker. As Darren said, if they were on a PPI at home, I continue the PPI and use it as stress ulcer prophylaxis. So
we have not had any documented cases of acute GI.
No, but, again, I think the problem is what we would consider a GI bleed isn't what the trials consider a GI bleed.
Well, it's so variable.
Yeah.
They're all in there.
And, and how many times do we have bloody NG output? We'll say, oh, that's just trauma.
Yeah.
Maybe that was the GI bleed.
But does it matter, though?
No. That's what I'm saying. I think
Yeah, it doesn't matter.
it doesn't matter. That's
Because
the
you
whole
couldn't have
point.
done anything different. You didn't treat anything. You didn't do anything. It didn't
I
increase
agree.
length of stay, so who cares?
I agree. Now, but like what he's saying, maybe there's some people that can go from that number to full out bleed. I don't know who those are. I don't know if this changes when the person has acute leukemia, undergoing chemotherapy, no platelets, and an INR of 3. Is that person?
The last two would meet the criteria, right?
Well,
no, coagulopathy, right? So they
don't meet criteria.
Yeah.
But then do you treat them with H2 receptor antagonists or PPIs? And is that the group that now you say, you know what? I'm going to give them what I think is the best shot based on alkalinization of GI, even though there's no data? Or do you say I'm going to do exactly what I do for everybody else?
Well, because if you think that, then that goes back to your first question. If you think that PPIs are the best shot, then you should do it for everybody.
Yeah.
Right? I mean, if that's what you really believe.
I think it really doesn't matter.
Not necessarily.
But if you're saying that, you're saying, well, this guy's really sick, so I really want to make sure, so I really want to give a PPI, then you really should do it for everybody, if you really think that. I would think.
Not necessarily. I think, if you have antibiotic that's superior, we don't necessarily give everybody, Zosyn. We still give regular antibiotics. We don't think it.
Right.
I think it comes to the risk. If somebody doesn't have the risk of where they're going to, bleed, and that bleed will determine their clinical outcome, then if there's some risk there is a risk of mucosal, bleed, but you don't think if the blood, you can still control it, you could, take care of them compared to,
You know what I think at the same time?
I think you can stratify them.
Yeah.
That's what I'm trying to say.
Over 15 years or 16 years that these trials, or almost 20 years now that they've been studying this, we've had such a dramatic change in length of stay and length of mechanical ventilation and all the other stuff we're doing. I don't think we get people long enough they're saying within 48 hours you're likely to have mucosal injury. Our average patient's extubated at 48 hours. Most patients don't stay intubated that long. And I think most patients probably aren't even at higher risk anymore as maybe they were, and they were always ventilated, never being fed. Just let this pass.
Adult Rapid Response Team 4 East. Adult Rapid Response
DJ, can you go to that?
4 East, 1428. Adult Rapid Response Team 4 East, 1428.
I was just going to ask the same thing, did any of the trials talk about enteral feeding? Because that is supposed to be, preventative or, decrease risk or whatever versus someone who's completely NPO for bleed.
Yeah, no, I think they mentioned it as this needs to be the next step to look. I think right now, if somebody's mechanically ventilated and getting fed, I feel personally that the best practice is to give them stress ulcer prophylaxis.
Oh, yeah.
Because they meet one risk factor. Now, if somebody's getting fed and in the ICU, but still critically ill, that person probably doesn't need prophylaxis because they're not intubated and not coagulated. I think you have to have at least one major factor in my mind to qualify. And maybe out of this, what's going to come out is going to be we need to get, and Dean has been talking about this, and a lot of us have before, is getting people off these drugs is probably better than worrying which one we're going to start it on, because they probably only need it for 2 days. So who cares?
It
really doesn't matter.
If they're not out at home and they're not shocked, they're not on steroids, they're not on a ventilator, I usually pull them off too.
That's probably the biggest thing is it's such a short period, and that I bet you the cost isn't even $2,000 for the number of doses they're getting. If we actually stop it when it's supposed to be stopped, it's probably even a smaller difference in cost.
That might be true. But, yeah, again, I only looked at the ICU. So you would think that the patients that are not intubated, not on pressors, not whatever, are probably not ICU and are leaving the ICU?
Yeah.
And at that point, I don't have data because I was the only people that I talked to about the like interchange and the H2 thing were you guys. So that was the only data that I was actually looking at. Like if we did education for all of the hospitalists and I could pull facility-wide data, then that might give us better insight into like, length of therapy. But this is only based on Pyxis polls. This is not like patient-specific, like this patient got therapy for 15 days or something versus this patient got therapy for 2 days. Do you know what I mean?
And I think it makes a good point because the goal is to get them off of it before they're transferred out. So that doesn't continue days and days arbitrarily after they're transferred out of unit, because that was what was happening before. And the system was actually working on processes to improve that as well.
Yeah, I think there is the hospital clinical consensus group has a clinical practice that talks about patients on the floor and PPI use, and the clinical practice it is not recommended to give PPIs, but it doesn't say don't give them any. It says it's not recommended to use PPIs for prophylaxis on the floor.
Yeah, it's not recommended, and what's interesting about their data is that they, right now, inappropriate use exceeds appropriate use.
Right. Hey, Robert.
Hey there, ho there. Did I come out of the sky?
Yeah, you did.
We're so quiet.
Well, I think, I think that's probably the more important thing that we can learn from this trial is it probably doesn't matter what we use based on the data we have, because we use it for such a short time. It is something that has a very low incidence, and maybe the next step is to worry about getting rid of whatever you're using than the exact drug we're using. We need to use it for indicated cases, and then it probably, I agree with you, Devin. I don't think this data supports one over the other because it's not good data, and it's not that strong of evidence. And I think, Robert, would you agree at a system level, this is probably not something that needs a clinical practice or standardized practice yet?
Yeah, there are probably bigger fish to fry right now, and I think you hit on the key point. The key issue is we need to stop it when it's not needed anymore.
And we just, last year or something, when we were talking about doing these interchanges initially, that all the care sets changed. All the admission care sets, there's no PPIs on the admission care sets anymore. So they're like kind of leading you on the H2 route. So someone somewhere has already evaluated some data to say, we don't think there's a difference. Majority of people are going to be fine on an H2. Now, obviously, that was before this trial came out, or this meta-analysis, but...
Yeah, no, I agree. In fact, I was looking for it the other day, and you have
it's not
to
on the care set.
It's not on either the ICU or the...
Yeah, because I was wondering how we decreased usage so fast, and then I was like, hey, it's not even on the admission care set. That's how we got rid of it so quickly.
Nobody's ordering it anymore.
And you're pretty successful in the IV to PO conversion.
For them, yeah. I mean, for H2s and PPIs, it's easier. The more difficult conversions are the antibiotic conversions that people don't meet criteria. But if they're getting tube feeds on the vent, then their H2 or PPI typically gets converted to. So all they have to be doing is tolerating a diet, some way, some enteral feeding, and then their H2 or PPI will be administered the same way.
If you had to design a trial, what would your ideal outcome be that you'd want to study for this? What would you say, this matters?
I mean, it better be focused on value.
That's right.
Shouldn't it be like when you were saying that you have like traumatic bleeding or whatever, like that an intervention actually was required because of bleeding, because that's the stuff that costs money. You either need to intervene by doing an EGD, you need to intervene by giving blood products, you need to intervene by doing something, and so then you can associate a cost to that. But if there's no intervention that's necessary, it's just an incidental finding of blood out of the NG, and you did nothing, and it cost you nothing, then no one cares.
Right.
So
either that or powered for pneumonia and C. diff and that kind of stuff.
Yeah, that's the balancing factor. And, when you have something like this where there's so much controversy and no real clear direction, the question becomes, is it worth spending the resources to standardize it because right now And I'll go back to, all of the points that you guys have made are very, very valid. The incidence of stress ulcer bleeding is way down from what it used to be, and there are probably a variety of factors involved in that. And the arguments that H2 blockers probably are not effective enough to change even that small incidence, and the argument that even in the absence of data, we ought to go with the big guns because they are big enough to change that small incidence. I mean, it's all over the graph. And so the question becomes, is it appropriate to put resources into standardizing for the purpose of standardizing a clinical practice? And there are reasons to do that in the absence of evidence. And my favorite story about that is Intermountain Health. Back 20 years ago now, 20 years ago, they were looking at an ECMO study that came out of Italy that showed a reduction in the ARDS mortality of some 20%. And they were smart enough to say, compared to what? And the answer was compared to chaos, because they demonstrated in their own population that if you give the exact same patient parameters to different doctors, there's almost 100% variation in what their response is to that data in terms of ventilator management. Even more interesting, you give the same data, exactly the same data, to the same doc on a different day, 70% variation in how they manage that data. And so the first step that they did is to look, we don't know what best practice is, but let's reach consensus and standardize it. And what they found when they did that is they reduced the mortality equivalent to the ECMO just by standardizing when nobody knew what best practice was. And when they added ECMO, there was no change. So, don't discount the value in simply standardizing the way that we do things. The other advantage that that brings, of course, is if you know what your current practice is and somebody comes up with an idea, let's test this and see if it works, at least you've got a standard against which to compare.
Yeah, and I think, the one important thing there was chaos in the other end, and that chaos had clinical consequence. And the question, I guess, in this case is, does the chaos of how we treat this have clinical consequence? Much like, managing bad ARDS.
Yeah, it's a great question. And the only thing I would push back a little bit on is in an individual ICU or an individual patient, 2 days of PPI versus 2 days of H2 blocker, you look at that and you say that cost is trivial. You multiply that times 1 in 200 admissions in the United States, and all of a sudden that starts to add up to real dollars. So even if we don't do anything, there is cost involved in prescribing medication A versus medication B. And I'm not pretending that I have the right answer, because I don't. And I still stand by, probably there are bigger fish to fry. The more important thing here is once they're out of the woods, stop it.
Well, to that point then, if you're saying that the initial injury doesn't even happen for 24 to 40 hours, what would you say to let's not treat it at all for 48 hours?
Yeah, and that's a great point, because as Shiva pointed out, most of our patients are off the vent by then anyway.
So should we just not treat for 48 hours? That would save a ton of money, I would think.
Our average ventilator days right now are running about 3.5.
Right.
So if we didn't treat for the first 48 hours with anything, I would think that would be even more substantial.
Yeah, and then we would probably have to put some clinical decision support in, because I think the reason that we treat pretty effectively now is because it's on that admission order set.
Yeah.
And if you have to remember to do it at 40, I'm not saying it can't be done, but it would take some design thought to make sure that we had the right prompts.
But that's a good point. That's definitely never been studied. But it makes physiologic sense based on how this works. That's a good thought. A question. Go ahead. What are you going to say?
One of the risk factors, you say, is more than 48 hours on
right.
ventilator.
So should we start it at 48 hours?
Yeah.
No. One other question came in. What do you guys think of tracheostomy patients? Do you start or keep them? They're obviously more than 48 hours for inevitable time. Do you always maintain these patients on this drug?
I guess I do. As long as unless they're trach collared for the whole time, I guess I do.
You're talking about trach on a vent,
yeah.
Right?
Trach on a vent. I'm assuming on a vent. Yeah.
Yeah, this is Bhavesh. I'm from iCare. I'm the one that submitted that question. My question was patients that are on chronic vent with a trach.
Yeah.
Do they require stress ulcer prophylaxis?
That's a good question.
You're talking mostly to intensivists here, so.
They
I would hope that there's.
It's interesting, but they probably wouldn't meet any of the criteria, right? So they wouldn't be critically ill. They wouldn't be septic. They wouldn't be necessarily coagulopathic.
I would say in an they're critically ill, and therefore, I would hope a real reason. I would maintain that they would need some degree of stress ulcer prophylaxis, but this would be one category where I would probably worry about what their chronic disease is, and if they have bad peptic ulcer disease or something, continue it. But outside of that, probably not.
It's kind of interesting to me because the reason we started looking at this here as one of our diet codes over a year and a few months ago was to look at the incidence of C. diff and if we were seeing a higher incidence because we were having some issues within the hospital. But like this study, we haven't seen that. We haven't seen any significant changes or significant increases in C. diff based on what we use or what we don't use. So for data to support this.
Yeah. At the SCCM conference last year, there was a big thing on stress ulcer prophylaxis, and I guess the big push from an outpatient setting, again, it goes to stopping these drugs. There's a higher rate of community C. diff that's come up, and one of the things that they're thinking is it's because of overuse of PPIs in the community. So we might be contributing to the overall, health system by increasing rates of C. diff by prescribing these, for patients that don't need them. So, when thinking about our organization and the whole system, this is another reason to say stop it when they don't need it anymore. But you're right. I don't think it's shown any difference in our practice here.
That's interesting you say that too, and I just kind of this connection together in my head that like PPIs people tend to take, religiously because you need to take it for a while before it starts to work, Like if you have indigestion, it's not like you pop a pill and then it feels better, whereas you can pop a pill of an H2 or of an antacid and it feels better, so it's more like treat as you need it kind of thing, where PPI is I just do it forever to prevent it from happening. And so maybe that's part of the difference in terms of like increased risk with one drug versus the other, whereas one you take all the time and the other is more intermittent versus every day. Because, like, I wouldn't just chew Tums every day,
Makes
just
sense.
because.
Makes sense. All right, any other thoughts or questions? All right, excellent. Thank you, guys. Thank you, Robert. Thank you, Bhavesh, for calling in. Thank you, Jijo.
Appreciate it.
Thank you.
So we're doing the same difference.
Yeah.